think we can start. So, good afternoon, everyone. I'm Izak Scholtz. I'm one of the third-year emergency medicine registrars at WITS. Obviously, a massive topic, that weird and wonderful diagnosis that will catch you off guard so many times. So, let's get on with it. So, obviously, we all know what PE is. It's an occlusion of the pulmonary vasculature. It's usually from thrombi, which originates elsewhere, and it's most commonly in the lower limbs and or the pelvis. So a little case study, we have a 35-year-old female who presents with a one-day history of dyspnea, chest pain. She reports a background history of generalized anxiety disorder and poor compliance with her oral contraceptive. She also reports that she traveled overseas 3 weeks ago. So what is your differential for this patient? So obviously, I mean, this talk is on pulmonary embolism, so it has to be on your differential. But for us in emergency medicine, you always want to think about the life-threatening causes of chest pain. So you'll go through that whole list and you work your way through until you decide who has a PE and who has not, and that's what we're going to be looking at. So if we want to investigate for a potential diagnosis of pulmonary embolism, we need to determine the patient's pretest probability. And to determine this, we actually need to risk stratify our patients. So symptoms on presentation, you can broadly categorize them as typical features or atypical features. So we all know the typical features: the tachypnea, the tachycardia, the pleuritic chest pain, and then obviously the extremes: hypertension, the cardiovascular instability, clinical DVT. Atypical features, however, they might be asymptomatic. They might have unusual fatigue. They might have fever, nausea, vomiting, and syncope. So it's such a broad spectrum of presentations that you really need to be sharp when you're thinking, is this a pulmonary embolism, yes or no? And that brings us to the PoCUS trial, the prospective investigation of pulmonary embolism diagnosis. That was an article that was published in the New England Journal of Medicine. And they actually found that 66% of patients presented with dyspnea, pleuritic chest pain. Only 54% of patients presented with tachypnea. And then the tachycardia, the one sign that we always love to hang our hat on, only 24% of patients presented with a tachycardia. And Stein et al. Did a systematic review on the presentations of PEs and stuff, and he found that 38% of patients with a DVT had a silent PE, which is quite scary if you think about it, you know. And then it depends on what podcast you listen to, the expert opinions on EM cases. Their take is, if you have a patient with exertional dyspnea and unusual fatigue, this is quite suggestive of a potential PE, and you should really take that seriously when a patient reports that. Obviously, you need to ask questions to get the correct answers, but have that in the back of your mind when you take a thorough history from your patients in the ED. So risk factors, we can use the nice mnemonic thrombosis to remember all the risk factors. I mean, emergency medicine is quite easy. We like to keep things simple. And what better way to use an acronym that is essentially the disease process? So if you go down trauma, travel, hypercoagulable state, recreational drug use, if you have malignancy, if you're on birth control, obesity, surgery, immobilization, and then sickness, which seems quite broad, but there's a specific set of diseases that are known to cause PE, you know, or that's linked to PE. So coronary artery disease, CCF, COPD, vasculitis. We all know in our demographic population, HIV, coagulopathies, lupus, and then obviously COVID that we've had a few years back. So this paper by Fleur, she looked at the localization of PEs and unexplained acute exacerbations of COPD, which was a systematic review and a meta-analysis. So they've established, we know there's a good link between inflammation and thrombosis. And this study was really to see what is the incidence of PE and unexplained acute exacerbation of COPD. So they looked at 22 articles. Um, or well, they reviewed 22 articles, and 7 was included in the meta-analysis and systematic review. And they found that there was an incidence of 16.1% of unexplained or well PEs and unexplained COPD, and that was in a total of 880 patients. So, I mean, when I read this, I thought, oh, I wonder how many PEs I've missed in the COPD patients. Obviously, you need to look at the common things that occur commonly. I mean, we know they're prone to respiratory tract infections and they're all still smoking. So is it just seasonal changes? Is it just decompensation of the COPD? But this is something that we need to keep in the back of our mind. Also, again, a nice article that was done by White et al. It's actually quite an old article. It's 20 years old. But they found that 50% of patients diagnosed with pulmonary embolism had no apparent risk factors. I mean, that blew my brain. I think we sometimes get so focused on what is the risk factor that we forget that patients can have a PE for no reason, you know? And that brings us to how do we risk stratify these patients with clinical prediction scores? Because that's what we do in emergency medicine. We weigh up risk versus benefit. So your clinical gestalt, there's numerous studies showing that clinical gestalt is as good and sometimes even better than using a clinical prediction score. So we'll go into each of these scores a little bit. Obviously, I don't think any of us can recall these scores from the top of our head. That's why we use MD-Calc. It's so nice. It tells you when to use these things, what's the pills, when should you avoid it, and it gives you the evidence behind it. So most of these scores are obviously validated. So your PERC score, so your pulmonary embolus rule-out criteria. So we should be using this to exclude PEs in your patient that's deemed low risk. So they say less than 15% suspicion, which I think is a bit of an odd number because I mean, what is 15% now? But that's what the literature says. So obviously you need to score a no on all these questions. But even if you fail the PERC score, it doesn't now automatically mean you need to go and investigate this. So it doesn't force you as a clinician. But we should be using this for our low-risk patients to say, look, patient's PERC negative, I have a low suspicion for PE, and not pursue that anymore. I mean, you're going to save your patient time in the unit, and you're going to save your patient exposure to radiation. So, I mean, it's a good scoring system in your low-risk patient. Then the famous Wells criteria, we all know that. There's an element of your clinical gestalt that you need to put into the scoring system. So is PE number 1 diagnosis or equally likely? So that makes it a little bit more of a subjective score. It's not validated for pregnancy and postpartum, and then you can decide, do you want to do a 3-tiered versus a 2-tiered system? It seems from my reading that the 2-tiered system is preferred. And when I refer to two-tiered, the patient's either low risk or high risk, and you use 4.5 as your cutoff. That's also the current recommendation from the American College of Emergency Physicians. They prefer the 2-tiered system, but you'll still find going through some units or some of the literature where they use a 3-tiered system, where you'll put them as low, moderate, or high. So yeah, obviously you know your protocols, but again, MD-Calc is your friend. Then another scoring system, which I think is pretty nice, just because sometimes if you're in such a busy unit, it takes away that cognitive load, the clinical gestalt. Yes, it's important to have that and always trust that, but sometimes you just need a scoring system to help you risk stratify your patients. So the revised Geneva score is to risk stratify patients into low, medium, or high risk based on history and physical exam. It's used as an alternative to Wells in patients who are low enough risk to rule out P with a score and a D dimer. And the whole aim is to avoid a CTPA unnecessarily. Obviously, if the patient's high risk, you're going to progress to a CTPA. So the original Geneva score actually required a chest X-ray and an ABG on room air, and they've decided to remove that, and they revalidated the score because of that. So you can see there, obviously you can't use the system or can't use the score in pregnancy and postpartum. And again, it is there for us to risk stratify our patients. So if you suspect a possible PE, a patient that scores 0 to 3 would be considered low risk, so less than 10% incidence of PE. Then your intermediate risk will be between 4 and 10, and that's where you go with a dimer. So if your dimer is negative, you can consider stopping your workup. If your dimer is positive, you're going to obviously go to ultrasound and CT, and if your CT is inconclusive, you will then consider a VQ scan or angiography. And then obviously if your patient's high risk, which is a score more than 11, you have a more than 60% incidence of pulmonary embolism, and then obviously you're going to investigate this patient with appropriate imaging. The years criteria, this has made a lot of news. It's been discussed a lot in the literature because the scoring system is actually validated in pregnancy and the postpartum period. If you add a TVT scan, obviously it automatically requires a D-dimer, which might be an issue because we know D-dimer is such a poor test because it's raised for so many reasons, but if it's negative, it's excellent. But then also they use adjusted D-dimers based on the risk score. So we should be using this in hemodynamic patients older than 18 with a suspected PE. Just to note, the original study included actually inpatients and outpatients when they were validating this, but they've excluded patients in the original study who had been on coagulants for more than 24 hours, or they had a life expectancy of less than 3 months and a contrast allergy, obviously, for the CTPA. So pills and pitfalls, know your value that the D-dimer is reported in. So is it FEU or is it DDU as so D-dimer units or something? Just make sure, because obviously it's going to be a different value. So you'll see the scoring system takes into consideration are you pregnant or not, and then it takes the 3 most predictive criteria of the Wells PE scoring system, and it's essentially if you have a score of 0 and a dimer of less than 1,000, it's negative. A score 1 or more plus a dimer of less than 500, you can also say it's negative. Again, if you follow MD-Calc, you put in your data and you say next steps, it will obviously guide you. This is just a nice flow of how they think or how they want to use the years criteria. So just to know, it was developed and validated in the Netherlands. So in the original study, they had 3,465 patients and they were followed up for 3 months. Actually, 85% did not meet the criteria and did not receive a CTPA. In this whole cohort, 7 patients had symptomatic PEs by 3 months and 2 were fatal. Of the 15% of patients that had CTPAs, 11 were symptomatic and 4 were fatal. They did think of age-adjusted D-dimers in this, but they've noticed if they do that, they'll actually do more CTPAs. And they would have missed 4 of the confirmed PEs. So they concluded that age-adjusted D-dimers would have doubled the sensitivity of a year's criteria. So it's not just something to keep in mind. So I like this algorithm. It's quite easy to follow. This is obviously another algorithm which was found on the Canadian emergency medicine site. And this is specifically for your pregnant patients. So, I mean, if you stick to the scoring systems that we've discussed, you'll be fine. But just know this is the general um, algorithm that the Canadian emergency medicine uh, trainees, consultants, MOs use. Then age-adjusted dimers, the big study there, the Adjust PE study. So they wanted to know, does an age-adjusted D-dimer value rule out PE in patients with a low or moderate pretest probability? And they actually found that compared to the D-dimer cutoff alone, if you use an age-adjusted D-dimer with appropriate pretest probability, there's an increased number in patients who PE could be ruled out without a significant increase in the number of PEs that were missed, which is really nice. Okay, so again, just how do you adjust your dimer? So if you have fibrinogen equivalent units, it will be age times 10 and then your D dimer units would be age times 5. Okay, again, this is on MD Calc. So pull out your phone if you're not sure, and make sure that you document this in your file. Then this is essentially all of the criteria that we've discussed placed into one thing. So, do you have a suspected pulmonary embolism with hemodynamic instability? Do your pre-test probability with your clinical gestalt plus minus your prediction score. Is it low risk, intermediate risk, or high risk? Obviously, high risk or easy. But I do find this low and intermediate risk is usually where we struggle a bit. So, can you use a PERC score? No or yes. If you can use it, it's negative. Great, we don't have to investigate. If it's positive, you go to high sensitivity D-dimer and move on from there. Obviously, while this is going on, you are going to do other things for your patient. You're going to want to do your bedside investigations, which, I mean, we can talk about for ages, your ECG and pulmonary embolism. And you'll see I've put up a few ECGs that actually comes from Life in the Fast Lane and some from Dr. Steve Smith's blog. So ECG is, I think, super important in your workup of your patient, and it will give you clues. Patients don't read the textbook, so the more data points we have to support our diagnosis of a suspected PE, the better. So sinus tachycardia, most common abnormality seen. So about 44 patients with a PE will have a sinus tachycardia. Cool. So just normal sinus tachycardia on the ECG. Then this is the ECG that you look at and you're like, this does not look good. So I think we can all appreciate the strain pattern with a T-wave inversion in the precordial leads, so V1 to V4, and then also in the inferior leads. So this ECG pattern is actually associated with high pulmonary artery pressures, and this is the most specific finding in favor of PE. One of the studies that they've quoted says there's a specificity of up to 99%. Obviously, it's only in one study and it hasn't been reproduced in other studies. So might take that with a pinch of salt, but obviously this should raise concern for significant increase in pulmonary artery pressures. Then 18% of your patients can present with this type of ECG. So depending on your QRS, is it a complete or incomplete right bundle branch block? Your patients with a right axis deviation or even an extreme right axis deviation, about 16% of patients will present with the ECG or whatever ECG like this. And then your dominant R wave in V1, which is essentially a manifestation of acute right ventricular dilation. And unfortunately, don't have the statistics that goes with it, but it's an important clinical finding. And then for med school answer to PE, the S1, Q3, T3, so the deep S wave in lead one, the Q wave in V, and lead three, and the inverted T waves in three. It's not sensitive, it's not specific, it only presents in about 20% of patients. So I know we've all been taught look for S1, Q3, T3, but actually, if you have 5 patients, I mean, only one will present with it. And then obviously just your right atrial enlargement, so your P pulmonale. Look for it in lead two. Obviously, again, taking into consideration the history, what your patient presents with, your clinical findings, there's a whole differential for peak P waves. But in the correct setting, this is just another data point that's going to support your diagnosis of pulmonary embolism. And yeah, chest X-rays, obviously, this was heavily relied on back in the day when CT wasn't as readily available. So most of the findings that I'm going to discuss was actually, if you go back into the literature, the 1940s, 1950s, but I still, again, all these patients are going to get chest X-rays because you want to look, is there any additional diagnosis? So the classic findings, raised hemidiaphragm, pleural effusion, the Westermarck sign, Hampton's hump. So actually, 75% of patients with pulmonary embolism have X-ray findings. And in young patients with pleuritic chest pain and a pleural effusion, it does increase your likelihood of a pulmonary embolism. But just to know that the Westermarck sign and the Hampton hump, it's a low sensitivity. Okay, so don't hang your hat on it, but nice to see if you have it on X-ray. So, I mean, straightforward. Elevated right hemidiaphragm, also numerous causes for that. Pleural effusion in the right population might be indicative of a P, but also wide differential for other diseases. Then the Westermarck sign. So you have oligemia distal to the large occluded vessel. So you can see down here. It's caused by impaired vascularization of the lung. Obviously, there's a plot. And this is, yeah, like I said, due to mechanical obstruction or to reflex vasoconstriction. Again, sensitivity and specificity is poor, but something to look out for on X-ray. Obviously, it's usually done in a retrospect. My patient had a PE. Let's have a look at the X-ray again. So yeah. Then the Hampton hump. So if you look at your X-ray here in the where my marker is, you'll see there's a well-defined pulmonary pleural base opacity, and this actually represents hemorrhage and necrotic lung tissue. So it's this medial margin of opacity with a medial curve that's directed to the heart that they describe as the Hampton hump. Then the Fleischner sign, honestly, I have not heard of it until I went and did my research for this talk. Maybe I just missed it. But you can see there, they've pointed out nicely for us. So it's a prominent dilated central pulmonary artery. It's associated with a massive embolus. And then obviously it enlarges, yeah, the proximal luminal diameter will enlarge, obviously, because of the occlusion. Again, it has a low sensitivity. They also describe in conjunction with a Fleischner sign, this is on your CT, but you get what you call a knuckle sign, and that's where you get this tapering of the occluded pulmonary artery, and it looks like a knuckle of your hand on CTPA, or well, best appreciated on CTPA. Then the Chang sign, I mean, it's a dilated left or right ascending pulmonary artery. You can see it's again marked for us, and it's just because there's an abrupt change, and it gives this amputated appearance. It's most commonly associated with a pulmonary infarction and pulmonary hypertension following your PE. Again, I mean, if you see it or you don't, I mean, you probably will still get a CTPA. So, but it's good to go back to the basics and have a good approach to your exercise. Then lastly, the Palestine, it's described in the setting of the right descending pulmonary artery enlargement, and it has this characteristic sausage shape appearance. You can see there, they've marked it out with markers. Okay, cool. That's the x-rays. Have a look. If you see it, nice. For us in emergency medicine, there's something we like more than x-rays, and that is PoCUS. So, I mean, we're going to delve into the magic behind point of care ultrasound just now. Just to note, there's no single echo parameter that provides a clear cut assessment of your right ventricular function. If you have an increased right ventricle to left ventricle ratio, or you have a D-shaped septum or McConnell sign, whatever, it's more data points for you to say, look, there's increased pulmonary artery pressures, and that's what I'm seeing on the right side of my heart. Okay, so it should be history plus clinical exam plus bedside tests, and they should all be used in the aid of to aid your diagnosis of PE. I don't know if there's any echo fans on the group. I don't know if anyone wants to give it a go to list a few echo features of PE. Okay, gone. Let's look at the echo features. So, RV dilation, systolic dysfunction of the right ventricle, McConnell sign, moderate to severe tricuspid regurgitation, a D sign. Do you have atrial dilation? Do you have a right heart thrombus or clot in transit? And then obviously findings with your IVC. And this is just a little bit like a nice little summary of what you're going to look for. But I find this more useful. Obviously, a lot of things that you can see on echo. Obviously, we don't have time to sit and do an echo for an hour. But, if you find these things again, it's good data points for your diagnosis and in terms of how you're going to risk stratify your patient. So we won't delve into all of this. This is just a nice cheat sheet on things which you can find in the setting of suspected pulmonary embolism. Obviously, we can talk about this for hours, and I won't be delving into how we do everything on echo. Cool. So, first echo, you'll appreciate here if you look at your echo findings, there's obviously right-sided dilation. You can appreciate the right ventricle to the left ventricle ratio is more than 1. So the normal ratio is actually 0.6 to 1. So obviously the right side must be smaller than the left side. It's not a rule out. Specificity is 98%, but the sensitivity is only 4%. 50%, I mean, sorry. There's measurements, and I'll post this after the talk, where you're going to measure, like when you do your apical four-chamber, which is this view, you'll do across the base, the mid-cavity, and then the apex. There's different findings. Okay. Also, there's features you can look and see if it's chronic or not. So if you look at the right ventricular wall, is it more or less than 5 millimeters? And that's a mark of chronicity. Then the classic, what we call D sign, or the abnormal septal motion. So this is due to acute rise in your pulmonary pressure, and this just means in systole, because of your elevated pressure, the right ventricle faces increased resistance to pump blood into this pulmonary vasculature, and your contraction time actually prolongs, and then as your left ventricle starts to relax, you get this paradoxical shift of your interventricular septum into the left ventricular cavity, and that's what gives us this D-shaped ventricle. Then again, this is an apical 4-chamber view, actually apical 5-chamber, because you can see the aorta in the middle. But if you look in the near field, you'll see this paradoxical motion of your apex. So that's what we call the McConnell sign. So it's akinesia of the mid-free wall. So up here, it has a 77% sensitivity and a 94% specificity for the diagnosis of pulmonary embolism. MRI studies suggest the mechanism of McConnell is that this hyperdynamic underfold left ventricular apex pulls on the right ventricular fibers, and it gives this appearance of hyperkinesia in the region. Obviously, there's other things that can also give you a McConnell sign, so right ventricular infarction or just good pulmonary hypertension. Okay, so if you see this, think of other things, but in the setting of a P, it's quite a good sign to see. And then again, on your apical 4-chamber, if you put some color over your tricuspid valve and you see that jet, that is tricuspid regurgitation, and that's important because it brings us to the 60-60 sign. So if you remember something, I mean, we see them all over the road. Check the 60-60. So the 60-60 sign, there's a nice video on core ultrasound by Jacob Avila. So it's where you look at two things. Okay, so you're going to look at the pulmonary artery systolic pressure and your pulmonary acceleration time. So again, for the pulmonary artery systolic pressure, you do your apical 4-chamber with color, and you're going to put a continuous wave Doppler through your tricuspid regurgitation, and you're going to get a value. So, and that's going to be in millimeters mercury. And then you're going to look at your IVC. And this is a guesstimate. If it's small, it's a 3. If it's mid, so it's variable, but not too much, not too little. It's just there in the middle, 8. And then a non-collapsing IVC would give you 15. And you combine these two values, and it's positive if it's less than 60. Then the second part of your 60-60 sign is your pulmonary acceleration time. So you're going to do a parasternal short axis, and you're actually going to look and find your aortic valve, so that Mercedes-Benz sign, and then find your pulmonary artery, and you're going to do pulse wave, and you want to see from the time of systole to the max, and you're going to just measure that time. Obviously, if it's less than 60, again, it's a positive finding. And this is just a summation of your 60-60 sign. If both are present, it has a 94% specificity for pulmonary embolism. Okay, so it's actually a really good test if you have time to do it. So yeah, again, like I said, on core ultrasound, there's a nice video on how to do this exactly. Another thing that seems to be very or an excellent finding on echo based on one of the studies is what we call early systolic notching. So again, looking at your parasternal short axis and putting pulse wave through your right ventricular outflow tract, you're going to measure, or you're going to just see in systole, do you have a notch in that in systole on your pulse wave? So it's a binary question, is it present or not? If it's present, it's highly sensitive and specific for submassive or massive P. But this was based on a once-off study, so we need more data to really appreciate this. You can see no early systolic notching on the left, and on the right you can see it, the early systolic notching. This is the study I referred to. So it was a retrospective analysis of patients who had a CT diagnosis of PE. They did the echo within 2 days, and they wanted to see how reliable ESN is for diagnosing submassive or massive PE, and they actually found a sensitivity of 92% and a specificity of 99%. Again, good additional data point. However, they've only done one study, so we really need more data to suggest that this is actually a core echo finding. But again, keep it in your armory for diagnosing PE. Great. So your patient went for the CTPA. We can classify this as a massive, submassive, low risk or high risk, or non-massive for low risk PE. Okay, we won't be talking about CD findings, just because it is something that the radiologist will look at. Obviously, you need to know a little bit about it, but it's not the bulk of the talk. The next part of the talk is going to focus on your sick PE patient, because that's what we want to know. We want to know how to deal with a sick patient with a massive or high risk submassive PE, where we actually need to intervene to prevent morbidity and mortality. And I really like this algorithm that the IBCC has posted. I think it's quite easy to follow, and it doesn't say that you need a CTPA. You know, if you look, you have enough findings where they do say, are all three of the following criteria met? But I mean, we do work in places where CT is not always readily available. So then you have to little deviate from your algorithm. But I think it's such a clear, well thought out algorithm. And obviously you just need all these data points, and you're gonna get most of these things. So yeah, it's on the IBCC. They have an excellent talk on the high risk submassive and massive PE, and you'll see we will refer back to this algorithm a few times. So for us, obviously, we are now suspecting massive PE because we've done our echo and our ECG, and there's right ventricular dilation. We don't think there's any causes for hemodynamic instability, and we managed to get a CTPA, and there's a large clot burden. Obviously, these parameters on your vital signs are quite self-explanatory. I mean, if you're in cardiac arrest, that all puts you in the massive PE group. And then if you don't have any of those on your clinical findings, you'll move down to see is this a low submassive PE or the higher submassive PE. And this is the area where there's a lot of research going on as to what should we be doing with these patients. So for your patient who you now think has a either submassive or actually a massive PE and they're quite unstable, so a little cheat sheet on how to treat these massive PEs. So the recommendation is early vasopressor use, just to prevent this hypotension that's part of a deathly spiral due to right ventricular dysfunction. Obviously, the right ventricle is descending, it's not pumping, it's decreased blood flow, and this just puts you into this deadly spiral. So, early vasopressor use, adrenaline is recommended as a first-line agent. You aggressively want to target that map for at least more than 65, and then vasopressin is the second choice according to the literature. I mean, we all have adrenaline available, so you should be reaching for this first. In terms of fluids, it's not useful because your venous pressure would already be elevated in a massive or higher submassive PE. So only give it if there's a clinical indication. This is not the type of patient that you want to hit with a liter bolus and see how it goes. Okay, so no go. In terms of what you can do for your pulmonary vascular resistance, so you can do nitric oxide or epiprostinol, which is unfortunately not available in our setting. If you don't have access to either of these things, you can actually nebulize nitrocine, so 5 milligrams. On a molecular level, the nitrogen is metabolized to nitric oxide, and we know nitric oxide is a vasodilator, and there's multiple studies that confirm that it's safe to do so. So something to really keep in your back pocket. Um, if you want to go look at the evidence, I can post that as well, but there's been numerous studies, there's RCTs on this. Um, so yeah, and it essentially they approximate that it gives you about a 40% reduction in your pulmonary pressure with no systemic effects or like on the systemic pressure. So actually very safe, good thing to use if you don't have nitric oxide. Our next part is probably the bulk of a talk. So what do we think about thrombolysis and PE? It's heavily debated. Obviously, it's really hard to do proper RCTs and things on these patients just from a ethical point of view. So we know that these or that the data about thrombolysis and PE is extrapolated. It's from the stroke and ACS data. So initially we thought that if you give a patient thrombolytic in a PE, you will reduce their risk of chronic thromboembolic events and pulmonary hypertension with a essentially improved long-term outcome. This has been disproven by the PoCUS trial. The primary reason why we would be giving thrombolytics in P is to reduce the risk of sudden cardiac arrest. And they describe these three principles in the literature. So the first principle is you want to reduce the risk of cardiovascular collapse. So you want, or you're aiming for immediate reduction in pulmonary vascular resistance, which will essentially improve your right ventricular function and relieve the strain. So this was well described in the two multi-center RCTs, the MAPIT and the PoCUS trial, that confirm if you give thrombolysis in the appropriate patient, you reduce the risk of hemodynamic deterioration. And it suggests that it's about a 50% reduction in terms of cardiovascular collapse. So significant, but still, you need to know 50% of your patients might still well on progress to a massive PE and cardiac arrest if you thrombolize your high-risk submassive patients. The second principle is looking at alteplase specifically. There was this belief that alteplase increases your risk of intracranial hemorrhage, but that there's actually no high-quality data to support this, mainly because most of the studies were underpowered. If you go and do a reduced dose regime thrombolysis for your high-risk submassive patients, the risk of ICH is actually less than 1%. Sorry about that. Obviously, if you want to reduce your risk even further, don't give your alteplase and your heparin simultaneously. Okay. So reduced risk, reduced dose regimes actually carry very low risk. And you can see there, this is looking at the complication rates of the placebo versus the placebo-controlled RCTs. I mean, it goes all the way back down to the 1990s, where they look at alteplase, and then they also did a few studies on tenecteplase. Okay. I'm not going to go through that. You can go through that in your own time. But just of note, the ICH rate is actually not high. Then the last principle, like I said, we want to reduce your pulmonary vascular resistance and take pressure off that right ventricle. So you don't need to have a normal pulmonary pressure. You just want to reduce the pressure sufficiently enough to decrease your risk of sudden cardiac death. So even a moderate reduction in pulmonary pressure might be achieved with your reduced dose lytic. and this actually improves your patient. Okay, again, we will chat about reduce dose lytic, but it does carry a lower risk, and there's improvement in your risk-benefit ratio. So something to really discuss with your patients. For evidence, we know in massive PEs, we thrombolize. That is the standard of care. Yeah. Low-risk PE patients, we anticoagulate them. In emergency medicine, this is not really for us. This will be for your patients that are admitted to internal medicine, where they can look at things like the simplified PESI score and the modified Hessian criteria. So this is essentially just to gauge, can we manage our patients who are deemed low risk with PEs as outpatients? Okay. In our setting, if you work in the ED, this is not something you'll do. You will refer all these patients. But again, this is on MD-Calc, so you can just put in your data. And you can see there, if you have a score of 0, your 30-day mortality risk is 1%. So yes, we can treat patients as, well, on an outpatient basis if they're low risk, but that I would leave for the internal medicine or pulmonology team. Just to add to that, sorry, the reason why they looked at things like PESI and HESIAs, and this is now obviously US data, but they found that outpatient management for low risk PEs actually saved $4,500 so that's a significant number, So that's why they're opting for outpatient treatment for low-risk patients, which I found fascinating. But the last criteria is the modified Hessian criteria. I think this is a little bit more applicable to us. And given the setting that I work in the state sector, most of my patients will fail this criteria just on the social condition. So the bottom line is, if your patient's low risk and they don't fulfill the criteria, we can decide to treat them as an outpatient if there's appropriate follow-up. I think it might be easy in private, but definitely not in state. So now that we've spoken about massive PE where thrombolysis is absolutely the standard of care and low-risk PEs where we anticoagulate, what do we do about the submassive PE group where they have evidence of PE, they have evidence of the right ventricular dysfunction, but they're not hypotensive, they're not requiring vasopressors, they're obviously not in a cardiac arrest. So what do we do with them? And this is where a lot of research is happening. And you can see there's the Mapitol, the types, the Moppet, and they all looked at reduced dose regimes from the traditional 100 milligrams we give for PE patients. They're looking at 50 milligrams. Should we do 25 milligrams? Should we do 8, 16, 24 milligram infusion? So, and most of the endpoints are either what is your 30-day mortality, or is there evidence of right ventricular dysfunction of pulmonary hypertension? Okay. Again, you can see here there's also the top coat and the PoCUS trial, and they again looked at the same things. And if we want to really go into the PoCUS trial, so the fibrinolysis for patients with intermediate risk pulmonary embolism, they actually showed that thrombolysis does not affect chronic pulmonary morbidity. So that makes it really nice for us. Our approach should then be, we're going to give lytic to this high-risk submassive patient to avoid a cardiac arrest. Your low-risk submassive is unlikely to go into a cardiac arrest, but your high-risk submassive may still benefit from thrombolysis. And I said earlier, we just want to reduce your pressures sufficiently enough to avoid the arrest. So we then just need an amount, we don't know yet, is that 25, is it 50, to reduce this our pulmonary pressures. And this is where the study really focused on, should we be giving 50 or 25? You know, they used tenecteplase in the study, but um, we obviously in our setting uses alteplase. And it does seem like at a lower dose, we have an increased safety profile, and it should be something that we're thinking about. If you want to go and have a deep dive into this article, the famous podcast by Scott Weingart, the MCAT podcast, they really delve into this article and how we should manage high-risk submassive patients. And this is what they found. So the PE risk benefit continuum. So also nice. It's either massive or everything else in this area in between is where they're looking at. Do 25 to 50 milligrams of alteplase. We know everything will reach the pulmonary vasculature. That's why you don't need a high dose, and your risk profile really changes. So I think we will see in the guidelines quite shortly that we're going to go for reduced dose lytics in your high-risk submassive patients, just because we want to avoid cardiac arrest. This is from the IBCC, what they recommend we should be giving our high-risk patients. So your high-risk submassive patients who have no thrombolytic contraindication, we should be doing half dose. And if there's a relative contraindication, we should be doing like a quarter dose, 25 milligrams as a slow infusion through a peripheral line. Because we know, just based on anatomy and physiology, all your lytic will reach your pulmonary vasculature. Obviously, in massive PEs, we know we give full dose lytic if it's an arrest. Again, the criteria or the risk stratification algorithm that I referred to from the IBCC, this is the group that we really want to make a change in, or how we approach them. So the low risk submassive and the high risk submassive PEs, the rest are quite easy. And then last thing, other PE related therapies. Again, we can talk hours about this, but there is options for like catheter directed thrombolysis, chatting to cardiothoracics for mechanical thrombectomies or surgical thrombectomies. And then obviously if you work in a setting where it's available, you can do VA ECMO as a bridge to definitive treatment. Perfect. I know this was a lot. Is there any questions? Tammy, I think if there's no questions, we can conclude the meeting. Thank you so much. I know this was quite heavy, but it is a topic that I find an interest in, and I really enjoy managing these patients. They're so complex and they present sometimes so atypically. So, yeah,